technology here a little bit too, I think. That would be great. When we get to a certain point, we're going to have that. The nice thing about being the speaker after lunch is that if y'all fall asleep, I can blame the lunch and not my own boring discourse. The bad thing, of course, is that you all have lunch in your belly. So I really would like some interaction with this as we go through. Feel free to interrupt me. I am not opposed to questions. The down arrow with this or right arrow? Good. So what I want to do is, as mentioned, talk a little bit about, from the perspective of a practicing clinician, physician in the trenches, the ordinary and extraordinary measures or the proportionate and disproportionate means that we've talked about this morning. You've heard a little bit about hospice and palliative care. I'd like to expand on that, give you a little bit broader flavor of that, as well as the distinction that was called out earlier between primary and specialty level palliative care. And if we have time, we'll go through some cases, and if we don't, that's fine as well. The thing, we have a quote here, if you want to go quickly, if you want to travel quickly, I should move the arrow, oh, you don't see the arrow, oh, that's good. If you want to travel quickly, go alone. If you want to go far, you must go together. Okay? It's an African proverb, and we take that to heart in hospice and palliative medicine. You heard earlier that hospice and palliative medicine is a team care, team-based care. And one of the previous speakers used a term, and I'm going to suggest that perhaps the term needs a slight modification. The term was multidisciplinary care. I would suggest it is not multidisciplinary care, it is interdisciplinary care. And the difference is, multidisciplinary care is what I learned up the street in 1980, which is the doctor comes in and he writes his note. And the nurse goes over here and she writes her note. And the social worker comes in and they write their notes. And in those days, the charts had tabs. Y'all remember those? Anybody old enough to remember them? And we each had our own sections. How many physicians read the social worker's notes, do you think? Not too many, right? So interdisciplinary care implies that at some point, every single one of us is in the same room at the same time talking about that patient. You would be amazed at the power of that. Some of the greatest insights that I've ever had in caring for patients come from the bath aid. Think about it. Who's spending a lot of time with them? And they're awfully vulnerable at that point. Now, you're all familiar, I believe, with the ERDs, and of course, in the general introduction, it calls out this issue we've been talking about, proportional, disproportional. In a time of new medical discoveries, rapid technological developments, and social change, what is new, the latest 69 million slice MRI scanner with PET, etc., can be either an opportunity for real advancement, or it can lead to policies and actions that are contrary to the real dignity and vocation of the human person. And I have a video here we're going to try to show you if we can. And while I've got this coming up, hopefully the sound will work as well. And we're going to skip the ad here in 2, 1, 0.
Hello, Dr. Happy here. I am the hospitalist taking care of our patient today, Mr. Alive, but not really. I have never met him before. What can you tell me about this admission?
I am the ICU nurse taking care of Mr. Alive, but not really. He has been admitted to our hospital 22 times in the last 20 days. He was sent back from the nursing home this time with worsening Alzheimer's. They said he couldn't write them a check for this month's rent, and his middle gate is not good round these parts anymore. He also came back with acute exacerbation of blah blah blah, rule out lupus, metastatic friend or lung cancer, a creatinine higher than my 3-year-old can count, and, of course, a UTI, decreased urine output, and incontinence. Can I get a Foley order? Please? Oh, one more thing. Your night hospitalist partner consulted a bunch of other doctors. They are all waiting to discuss the case with you, and they are all wondering why there isn't a transcribed history and physical in the chart for them yet.
Boy, he sounds very sick. I'm looking at his old records now. Has he ever had a palliative care consultant? I don't see any mention of it. He hasn't been in the upright position in 3 years, and his functional score is -2, which places him at an expected likelihood of death within minutes.
I think that's a great idea, Doctor.
Palliative care consult it is. Indication, syndrome of imminent death. They do great work making sure the patient is very comfortable and all the family questions are answered appropriately. They are an incredible asset to our hospital. I don't know why they are so underutilized. Oh wait, what's this? I see orders in the chart from the cardiologist who rounded at 4 a.m. with their eyes closed to do a steady echo with uncalled stress test to follow an EEG. Oh wait, that's EKG cube went out until discharge. He is arranging for a heart cath first thing this morning in replacement of his 4-chamber pacemaker with defibrillator to include a portable iTunes music player. I see, in order to consent for placement of iPacer, billed under the CPT codes for music therapy as all other methods to ensure payments have been exhausted. Brilliant. That's why he's a cardiologist.
I'm not sure if he will get all those studies today, as he is getting ready to go downstairs for a hemodialysis catheter. The nephrologists are starting dialysis today. Do you want me to page the palliative care hemostat?
That might be necessary. A stand-down consult. Looky here. There it is. Dialysis orders in the chart. They must have called in some orders to start hemo as soon as possible during normal business working hours. But I'm not sure we will be able to get a normal basic metabolic panel before death. Everyone deserves to die with a normal BNP. But sometimes it's not possible.
Keep reading the orders, Doctor. I've had a very busy night entering my own orders since our secretary went home at 2 in the morning after being sick of too many orders to enter by our night hospitalist.
I apologize on behalf of all that makes sense in this world. I note also that Mr. Alive, but not really, is also scheduled by the oncologist to receive an off-label last-ditch experimental effort with a continuous infusion of green bean casserole.
Okay, you get the idea. Okay. Hyperbole.
It was an allergy to green beans, and when I woke up, the hospitalist last night who asked him what I should do.
Thank you. I'll go another just a little later on. So, hyperbole, yes, but you get the idea, okay? There is proportionate means and there are disproportionate means. In this country, we have extended life expectancy over the last 100 years by an incredible amount. And we have done so by some incredible advances in care. But have we done so at the cost of developing that human connection, that human relationship that we all so desperately need? And how do we recapture it? I mentioned to somebody earlier today that I like to think of it, and I apologize, I'm not trying to be offensive here to anybody, but I call it the Spandex Rule. Y'all know what Spandex is, right? The Spandex Rule is just because you can does not mean you should. Right? You do not want to see me in spandex, I can tell you that. But in healthcare, we do, don't we? You show up in the ED, and the ED physician earlier is, I'm sure will acknowledge this. You start going down your checklist, your protocols, and you don't necessarily have the time to think about, is this really what's necessary? Is this what's important? Hence the development of better end-of-life care methods, hospice and palliative medicine. Palliative care then, as we've heard, is specialized medical care, and it is not just for people who are dying. Care of the dying is one part of palliative care. Hospice, in fact, I would say, is a subset of palliative care. It was the first that was developed. It's probably the most well-developed, and it is one of the most effective healthcare systems that we have. But palliative care is available for those who have serious illness. Example, young person with an acute leukemia that could potentially be fatal, but could potentially be curable. Do you think for a minute that that person isn't going to be fearful, isn't going to have some spiritual distress, isn't going to be emotionally taxed, and may not have pain and other symptoms that we can address very, very effectively? Well, of course they are. And we may be able to pay attention to those, but our focus in the traditional medical model is get that cure, and appropriately so. But we need somebody stepping back and saying we need to look at the rest of them as well. The goal is to improve quality of life, patient and family care, the team, the NEH, any stage we've already talked about. This is a chart that sort of describes the differences between hospice and palliative care and the similarities. So for hospice, you have to have a terminal illness, and you have to have two physicians certify in writing that your disease prognosis is 6 months or less if the disease runs its expected course. How many of us know the expected course of any given illness? I have a brother who is an electrical engineer, wonderful fellow, but he gets nuts with what I do because he goes and looks at circuit diagrams. He says, if I put a resistor on this arm of the circuit, I know exactly what's going to happen in this system. If you and I go put a medication on this arm of that circuit, we know with about 70% accuracy what's going to happen because there's so many myriad inputs. Biology is not physics. So what is the expected course? And what happens if you don't follow the expected course? Hospice is everywhere. Currently, palliative care is primarily hospital-based. That's where the needs have been identified the greatest. There are outpatient palliative services developing. One of the big keys is hospice is paid. The hospice Medicare benefit was passed by President Reagan in 1980-something. And by the way, does anybody know where the 6-month prognosis number came from? The answer is Donald Reagan. Donald Reagan. Donald Reagan was President Ronald Reagan's Secretary of Finance. When they passed the hospice Medicare benefit, Don went to President Reagan and said, this is going to be expensive. We can't do this for everybody. How about let's limit it to 6 months? And that is the degree of scientific validity that 6 months prognosis has in hospice. I'm not making this up. Google it, okay? The focus for palliative care and hospice is the same. Palliative care doesn't have a reimbursement mechanism. The only payment you get for doing palliative care is what you can bill from it. As we move into accountable care models, that will obviously change. In my opinion, that's a good thing. I don't know if the way we're going is the right way. We will wait and see. Now, we're going to have a little quiz here. Remember I said a little interactivity. So I want to show of hands. You have today in front of you the opportunity to choose your final exit. Okay? You get to pick right now, imagine, if you would, how you will die. Think for just a moment and tell me, raise your hands, how many of you immediately said, I want to die of cancer complications? We got one. Okay, good. How many would like to die of emphysema, heart failure, liver failure, kidney failure, some type of chronic organ disease? Okay. Well, I got bad news because the rest of y'all are going to get Alzheimer's. You heard the statistic in the previous discussion that 10% of us die from acute illnesses? 90% of us are going to die in one of those three fashions. And here's how that looks. If you have terminal cancer, not your squamous cell skin cancers, not your leukemias, this is stage 4 lung cancer, okay, non-small cell lung cancer. When you get diagnosed, you're usually functioning at a pretty good level and you go along pretty well for a while until you hit a tipping point and then you fall off the cliff and you die. Talk to any oncologist, they will tell you this is what happens and that they can actually also predict when you're hitting that cliff, okay? This is chronic organ failure. These are your heart failure patients, these are your emphysema patients, these are your renal failures, your liver failures. You'll notice that when terminal disease is diagnosed, your functional status is not quite as good. And you then follow a sawtooth pattern. In healthcare today, where do we see patients? In the hospitals. We see them at their sawteeth. We see them at their worst. And what do when they show up? We rescue them. We make them better, right? But notice, they don't get quite as much better as they were before they come in. And each time, they get better, but you don't know when that last one is going to be. And the tragedy is when the family looks at you at that point and says, I didn't know they were that sick. How could you not rescue them this time? Well, if you look, where they started from was worse than their first exacerbation in the first place. And nobody's looking at that big picture to see that overall we're declining. This is the dementia. This is where you and I are all going to go. Yes, ma'am.
Just a comment on that last slide.
Yeah.
That maybe the family doesn't recognize it, but the patient does.
Generally,
That's when,
yeah.
if you talk to patients as they come back to the hospital, they'll tell you, I just really don't like I want to do this.
That's so true. The comment was that the families may not recognize that, but the patients often do. And the hard part, and one of the big roles of palliative medicine, is to connect those dots so that the patient feels safe and comfortable admitting to their daughter that, yes, I am dying, and it's okay. You don't have to do everything for me that you think is medically available. Excellent comment, thank you. This is where I'm at, this is where you're all going to meet. Both my parents died from complications from dementia. The variable onset, the extreme long time that you're in this. We are not dying acutely anymore, we are dying of chronic illness. Dr. Ira Byock, one of the experts in palliative care, in fact, has said that in this country we have invented chronic illness. Think about 1970s. Before I was in medical school even, what was the way people died? They go out and shovel the driveway after Thanksgiving dinner. What did we do? We developed EMS. We developed CCUs, heart caths, etc., etc. We need that same kind of response for end-of-life care from the country, from the healthcare system. We're not there yet, we're getting there. So this was also mentioned by one of the previous speakers, although I think her graphics weren't working well. So this is a visual of what she said. Previously, we would treat until you die. If you were lucky, you got hospice at the very end. Now we want to begin palliative care early in the illness, and it becomes more and more important as time goes by, whereas the life curative methods, life prolonging methods become less and less important. And the quote there I'll leave you with is that as death comes closer, medical care becomes less and less important. Right? When you're on your deathbed, do you worry about, here's the story. I do a few house calls, and I was honored to be asked to see a patient who was dying of liver failure from his chronic alcoholism. And so my secretary called them up and arranged it, and I was going to be there at 10:30 on a given Wednesday, and so I'm driving, and like I always do, I call them ahead of time just to give them the alert in case they're sleeping or not dressed or whatever. So I call this fella, hey, here's Dr. Sawicki here, I'm coming to see you. Well, Doc, I got a little problem. What's that? I'm not at home. Really? Where are you? I'm at the Copper Top Lounge, which is on the bad side of the town that he lived in, and it's a bar at 10:30 in the morning. Now, as I thought about it, and of course he asked me, can you come here? Well, I can't do that. But it occurred to me, here's this guy, he's probably got a month left of his life. What's more important to him today? Me coming to see him, or him spending time with his loved ones, his barmates? I saw him a week later. I mean, forget it. I'm just not that important to you at this point, right? All right, in the ERDs, as we've already referred to, we've talked about the need to instruct people about what their conditions are to help them be ready for that ultimate birthing. That was brought up earlier too, and I'll throw this one out there. Do your hospitals still play a lullaby when a baby is born?
Yeah.
Some yes, some no. Okay, for those who do you also play Amazing Grace when someone is born to heaven? Should be. When that's happening in my hospital, that's when I get to retire, but I've got job security. Palliative care has been called by at least one source a moral mandate for Catholic health care. That was a quote from Tina Pickey, who is the executive director of the Supportive Care Coalition, which is a national consortium of over 25 Catholic healthcare systems across the country, which originated in direct response to the Oregon Right to Die legislation. It's since expanded. I'm honored to be on their board of directors. I would submit to you that it's not just a moral mandate for Catholic healthcare, but for healthcare in general. But we as Catholic healthcare should certainly be the standard bearers of this. And for those who follow the statistics, we have been. If you follow the development of palliative care across the nation, it has been increasing dramatically over the last 10 years, and Catholic healthcare institutions even at a faster rate. We have embraced this within Catholic healthcare. But palliative care has been, in the literature, shown to improve patient satisfaction. Who would have guessed that, right? You pay attention to somebody's symptoms and they feel better and they like it? Who would have guessed that? They have better quality measures. Okay, you can actually look at some of these CMS quality measures and find improvements. Oh, by the way, it costs less. That's not the primary purpose. We are not, and I will personally throw a book at anybody who says the word death panel to me here today. We are not death panels. We are not people who are out looking for ways to save money and rationing your care as a result of that. We are, in fact, doing exactly the opposite. We are seeking your goals and your values of care and matching your plan of care to that, informed by our Catholic faith and tradition. And oh, by the way, as you heard, it may actually extend life as well. And there was not just the lung cancer study, but there was a study previous to that with heart failure patients who lived 90 days longer with hospice care than without. Now, if you had a medication that you had just developed, and it didn't cost much, and in fact was cheaper than current standard care, and patients liked it, and doctors liked it, and it made you live 3 months longer, how much money would you invest in that? But we don't have that pill, we just happen to have that form of care. I talked about the interdisciplinary aspect of it. The other thing that was mentioned was family meetings. Family meetings are an incredible source of both value and angst. Okay, as a family physician for 20 years, when I had a seriously ill patient in the ICU and somebody came up and said, well, the daughter from California is here. Oh boy, you know what? I just think I gotta go over to the other hospital in town for something. I don't really want to be here. Because the further away you live is an inverse relationship to the amount of difficulty you cause, right? So, and you understand why, right? Does everybody to get that? they haven't seen grandma for 5 years. Last time they saw grandma, they played golf with her. And here she is in an ICU bed, intubated with tubes in every extremity. What's up with that? And I'm coming in and I'm going to rescue the day. Well, that's where that comes from, of course. But a family meeting is something that you can accomplish more. A palliative care nurse told me this. You can accomplish more in 45 minutes in a family meeting than you can in a week without one. And I would say that's very, very true. And a palliative physician, that's why they went into medicine in the first place. So we talked earlier, the question was raised, isn't this just simply good medical care? And the answer is yes. But isn't taking blood pressure just good cardiology? Yeah. Do we need primary care docs and cardiologists? Yeah. We need primary palliative care physicians. We need specialty palliative care physicians and nurses and social workers and chaplains. The whole team. Basic pain and symptom management, general communication skills. When it gets tough, that's when you need to call the specialist. When you've got a heart problem, you need to call the cardiologist. When you've got difficult decisions, withdrawals of life support, disposition, planning, issues of that nature, that's when you need the specialty level. How do you do palliative care in the primary setting? Well, you look for the needs. What are the functional needs? Who's making decisions? Do you have advanced directives and advanced care planning done? Are your symptoms well managed? Do you understand your prognosis? Do we know how your value system informs your health plan? And does your family offer you enough support? These are all the issues that the primary care team needs to address. The patient-centered approach would be to design it, not based on physician opinion, but on patient needs. So many times, and you all have said this, I've heard this, how do you get the doctor to refer when they don't necessarily think they're dying? Well, that's why. You saw some of these already, what they want, what they get. If we don't do this, what are the consequences? So you could begin to talk about organizational ethics and institutional ethics for that matter. If you don't do good symptom management, it leads to suffering and poor quality of life. Poor communication has consequences for the patient, for the family, for the providers, and for the system. For the patients, they're suffering. They are getting care that's not consistent with their goals. They're getting that off-label IV intravenous green bean casserole infusion, right? They don't want that. And they're not able to close. For the families, they actually have a higher incidence of clinical depression, of post-traumatic stress-like symptoms. Okay? And I saw this illustrated for me once. A patient that I took care of, a young man, was 45 and had metastatic colon cancer, and he died. And as a family physician, I was privileged to care for his entire family. And his wife came to see me about a year later. And she came in and, how are you? Are you managing okay? We talked a little bit about that. And then she looked at me and she said, "You were right." Okay, good, I'm glad I was right. What was I right about? You were right when you told us that we should have taken that trip to Europe. Because instead, they went back for experimental chemotherapy, which developed complications. And he died from those complications. And she is now left with that unresolved guilt and grief that had I not done that. Now, we're not going to solve all of those problems. People have the right to make their decisions and to make bad choices. We can't mandate, doing what we think is the right thing. But at least we can help people try to see some of those issues that they may be facing and they can't see in the heat of the moment. Nurses at the bedside, moral distress and burnout. The example there is the patient who was 95 years old, admitted to the ICU from the nursing home with decreased mental status, found to have pneumonia, treated with antibiotics. You know the scenario. After they've been in there about 6 days, the palliative care team gets consulted. The team advises at this particular institution. They don't actually order, so they can only say, Dr. Jones, I think you should give morphine for this short-windedness. Dr. Jones says, I don't think I can do that because that's going to depress respirations. So here you have a 95-year-old in the middle of the night screaming in pain and in dyspnea with the appropriate treatment available but not being given. Tell me that that ICU nurse is not going to be traumatized by that experience, right? So if we don't do this well, again, the disproportionate cost and resource use. Dartmouth Institute did a study of costs in the last 6 months of life. And what seemed to make the biggest impact on what the cost of care was how many doctors you have. The more doctors you have, the higher the cost. The more MRIs you have, the more you use them, the higher the cost. One of the lowest cost areas, though, oddly enough, was in La Crosse, Wisconsin. Does anybody know why?
Respecting choices.
Bingo, respecting choices. Dr. Hammes and Linda Briggs and several others developed a community-wide advanced care planning effort for people to develop their advanced care plans, fill out proxy statements, et cetera, et cetera. If you walk down the streets of La Crosse, Wisconsin today and ask a random person if they've done advanced care planning, you have an 80% chance of getting a yes. What do you think that would be in downtown Chicago? Lisa, you got any guess? I'm guessing probably 5%. 8, yeah. I don't know, but it's not going to be 80. I can tell you that. Palliative care does reduce costs. When you get feeling better faster, you get better faster. It helps patients and families select treatments that are in concert with their own individual goals, and it coordinates discharge planning for that very same reason. Family meetings we talked about. For the primary team, they can be very difficult and time-consuming. Goals of care can be in conflict at the same time. I talked earlier about how you seek out what a patient's goals of care are. So if I'm a 88-year-old patient with emphysema, I may want to have a score of 0 on my short-windedness scale and simultaneously be fully alert and awake. Those are my goals. Well, let's talk about that. Which is more important to you at this given moment? Which would you be willing to give a little bit on, and how do you negotiate that? Because they can be in conflict. And as the disease moves on, those goals will change. It may become, I don't care if I'm awake anymore, just get this misery away from me somehow. And so these are just sorts of lists of the various types of goals of care. Prognosis, that was mentioned earlier as well. How do you give somebody a prognosis? And it's not so much about the time, really. It's more about what am I looking at, okay? If you tell me today I have metastatic colon cancer, what does that mean? Am I going to be able to go to the ball game this summer with my son? Am I going to be able to get out in the yard and mow the lawn? Yeah, I want to know, am I going to be alive in a year or not? If possible. I don't have a crystal ball, nobody does, but here's what we think, and you always give them a range. So when you call palliative care, well, again, when it's difficult. Symptoms, decisions, coping, disposition, or when the patient simply asks, we want to seek palliative care because they have had that. This one's kind of interesting. This is a study that was done, again, talking about bereavement care. If you talk to patients about their end-of-life discussions, their end-of-life decisions, it turns out that if you involve the families, that a year later they have a significantly lower incidence of mental health issues. And the interesting thing about this study was it was irregardless of any medication. You might say, well, this is because you're paying attention to it, so you give them more of a Prozac or whatever your flavor of the week is. No, they have the same degree. It's just having that conversation. It's involving them in their care. So palliative care reduces symptom burdens, increases satisfactions, earlier hospice referral, reduced costs, and possibly a survival advantage. What's not to love, right? So, well, as a matter of fact, there are a couple of issues that do come up. I mentioned one earlier, the death panel issue, right? While the issue of having someone else make decisions for us based on economic concerns is something we should all rightly be very afraid of, that's not what we're talking about here, right? And in the ERDs, it talks about that. Pope Benedict in Hartford, Vienna, talking to a hospice, talked about the proper response to end-of-life suffering, being loving care and accompaniment on that journey, especially with the help of palliative care, although you do have to take concrete steps to avoid the actively assisted dying. We're going to try the video one more time, and this is another hyperbole, so I'll warn you ahead of time. But this shows what some of those concerns might be.
Just, you know.
Euthanasia.
Just explore options. And this cold of yours, it's been over a week now. It's just like if it ever get around. You've always been such a proud, dignified man. And pretty soon you're going to have all that really ugly red chugging around your nostrils. I think you'd start to hate yourself in the end. It is a super clinic.
Well, if you could let me know in the next half hour, though, because we're almost out of Vapor Rabbit, it would be silly to buy a whole new tub. Going to Switzerland!
Okay, yeah, hyperbole, but of course that's the fear, isn't it? Is that we could easily, and you all have seen those, heard those arguments for euthanasia, for physician-assisted suicide, and you can see just the absolute lunacy of them, to be perfectly honest with you. But that is the concern. So just as a final example, and I have a couple of cases that I could discuss depending on time. I think I'm running short. No, actually we're good. 85-year-old patient with severe emphysema and coronary artery disease. And she has a mass. She's found to have something on her x-ray that looks really bad, probably cancer. So what do? We have a couple of options here. Do we send her for biopsy and or surgery? Do we send her to a cancer specialist? Do we send her to palliative care specialist? Do we refer her to hospice, or do we do something else? I'm sorry? Sit down and talk to her. Wow, what a concept, right? Figure out what she wants. So if she's 85 and she's got all these serious illnesses, does she need to go through a biopsy? Maybe. I don't know the answer to that. What will make that determination, I think, as much as anything, is do you know what that might lead to? Do you know what the risks are of that? You might have a pneumothorax. You might have need to have a chest tube in temporarily. Or you may find that it's metastatic cancer and we want to do a lobectomy, and then you have to be in the ICU for X number of days and go through chemotherapy. And Mrs. Is that what you want to do? And we can't do it in any type of judgmental fashion unless it's obvious and very clear-cut that this is the right medical answer. Okay, autonomy is clearly important, but it does not trump everything. Does not trump good medical judgment. If we find this patient And we believe that with simple interventions, she could be cured of this illness, or maybe we really believe it's not a cancer, that it's a pneumonia. We treat it, we don't just ignore it, we continue it. Being terminally ill, this is another Dr. Sheehan quote, being terminally ill is not an excuse for sloppy medical care, right? Just because you're dying doesn't mean you get to cut corners. You still have to think about it. But it's, again, I need to emphasize we're not trying to lead people down the path of do less, do this, don't do that. It's not about that. In the previous discussion about pulse, one of the things that I meant to mention and I've forgotten was that unlike the previous DNR form, which is what I don't want, the current Illinois pulse form is an opportunity also to say what I do want, including I want everything. You can have a pulse form that says, I want you to do everything. Do CPR, do full treatment, intubate me, take me to the hospital, all of that. And you have a medical order that says you can do that. I think that's a highly positive thing. We hear from physicians all the time, and I used to be one of these, and I still am a physician, although my wife may think differently. And you know what? My daughter likes to introduce me to her friends. She says, hi, this is my dad. He helps people die. No, I am not Jack Kevorkian. I help people who are dying. You gotta know my daughter. She's got that sense of humor. She's the one going into bioethics. Does that make sense? Okay, so my patient's not ready because they're not dying. Well, who's not dying? We're all dying, right? World death rate's still 100%. Medicare thinks that's a tragedy, but that's my loved one's not ready for palliative care because they're not dying. Well, reality is, from the patients themselves, we can't say enough good things about the ones who've helped us through these difficult times. Everyone's so good to help answer questions, provide necessary supplies and meds, and we thank God for all of you. And nothing at the end of the day trumps that. I'll leave you with this, and then open for questions. Anybody know who this is?
It's the cat that stepped the nursing home.
That's Oscar, yes. That's Oscar the hospice cat. He lives in a nursing home in Rhode Island, actually. And one of the studies that was in the previous slides was by Dr. Tino. Dr. Tino works with Oscar on a regular basis. Oscar is not a real personable cat. I love cats, by the way, I have two. He hisses at people, he's antisocial, but what they found was that when he jumps up on the end of their bed, of a patient's bed, you better be calling the family, because that patient is dying within 24 hours. He is yet to be wrong, and I tell you what, every night when I go to bed and the cat jumps on the bed, I get scared the Jesus out. So you can Google Oscar, and I open for questions. What can I answer for you? Yes, ma'am.
Is there a way to ensure that it's spelled out?
Good question. Is there a pulse registry? Not currently. Lisa, do you know?
They're working on one. It'll be a while.
Working on one. It will be a while. Is it Montana that has that now? Oregon has an electronic pulse registry. Illinois does not yet, but it clearly is one of the things that we do want to work on. That's a great suggestion.
I'd like to take this opportunity to thank you, Dr. Robert Sawicki. I have a late husband, George Francis Whitty, Sr. He died of Lou Gehrig's disease 8 years ago. And the thing is the point I want to make here is the providential care of God in all of our lives. Dr. Sawicki happened to be on a Cursil weekend with my late husband before he was diagnosed with ALS. Providentially, when in Dr. Sawicki's office, you told my husband of his prognosis, his diagnosis. He smiled and he said, oh, and then no way, you went into palliative care. And my husband said, Oh, you did that for me. So the kind of comfort, providentially, that happens in our lives. I want to make one more point here, too, and I don't want to take too much time, but I think it's important because ever since then, I'm so thankful to God for the kinds of care that all of you give. And I'm not in the profession, I'm just a patient, or not a person, you know. But anyway, hindsight, after my husband passed away, I found in his handwriting the ancient prayer to Saint Joseph that apparently meant a lot to him. And as I read it, I thought, oh my word, I was there, because it says, I never, talking to Saint Joseph, I never tire contemplating you, holding Jesus in your arms, press him to your heart, and kiss his fine head for me. And when I draw my dying breath, have him return the favorable. I thought, oh, so two things jumped out at me. Dying breath and kiss his head. The morning my husband died, I went in, and he was in hospice care at home. And I just felt this overwhelming love for him. I kissed him all over his head. He looked up at me, and I thanked him for being a good husband, a good father. Oh no, I told him, don't be afraid. Jesus loves you and I love you. And then I thanked him for being a good husband, a good father. I sat down because EWTN was on. Pope Benedict was coming into, he was going to be a pope. And then the rosary came on, and he died while I was praying the rosary. So this is kind of a long testimony, but I feel incredibly that God is in our lives and in every moment. And even today, and I even have another connection to Erica because my daughter Erica is going to have a baby, just like this Erica, she heard you. So I'm just going on and on how God is in every moment of our lives. So thank you, Dr. Sawicki, and thank you all of you. Bye.
Thank you so much. I really thank you for sharing. I do appreciate that, and it was an honor and a privilege to care for George. And he was a blessed man. And I will also reiterate something, and that is you talk about how providential these things are. I was in family medicine for 20 years before I got into hospice and palliative medicine full time. And as I look back, you can clearly see the steps God led me on that way to get me where I am. So I'm convinced he brought me here for a reason, for his reasons. And so here and then here.
I just have to say, my mother's been in intensive care. She's been through the whole room. She's now in a nursing home on a ventilator. And my sister and I are both nurses, and we have been kind of the advocates for my mother. But in the intensive care, I can't help but feel that the palliative care consult position that we requested was like the orphan child. He was, many of the team in the intensivists were just driven to procedure, find the diagnosis, find the problem, whereas the palliative care doctor was there, was supporting us, but it was not, he was not the team director, and that's where I feel like there's something
That's a real gap, and that's a gap in both ICU settings and in emergency department settings in many institutions. One of the things that's going on nationally, you heard earlier about CAPC, Center to Advance Palliative Care. Dr. Diane Meyer, who's in my mind the palliative care guru in the United States, leads CAPC, and she and Dr. Judith Nelson, all at Mount Sinai in New York, have developed a module for incorporating the principles of palliative care into intensive care units and into the emergency department, regardless of whether there's a palliative care team there or not. And there's actually quality measures that go along with that. It's an effort, it's in progress. Not there yet, obviously, and unfortunately, I'm sorry that that was your experience.
just one more thing that kind of on the same line of you were saying about time. When I had my children, we had a birth plan. I had a birth plan. Whereas I think more physicians need to discuss, primary physicians need to discuss with their patients, what is your life plan? What is your direction? That's not necessarily
It is still avoided, and that's a perfect segue to an acknowledgement once again that today is what? National Healthcare Decisions Day. This is the 6th year that today, April 16th, is National Healthcare Decisions Day, designed to raise public awareness about developing your advanced care plan. Why is it on April 16th? What was yesterday? Taxi. What are the two things certain in life? And I didn't make that up, all right? They did. 6 years ago, somebody came up with that, honest to goodness. But it is designed to help raise awareness. I would submit to all of you in this room, though, that the place to really focus efforts is across the street and up the street here. Our medical students need to have this, and our residents need to have this enculturated into them from the very beginning. And where does that come from? It comes from their attending physicians and from their residents. So we really need to get it at the very beginning. Was there another? Yes.
I think what the best part about working in Catholic healthcare, at least for me, is the fact that I can walk the walk and talk the talk. And where previously that's been discouraged. And my faith has only grown stronger because of where God put me. I had 4 early maternal losses, and I questioned them and questioned them and questioned them. And it turned out to be divine intervention. That's my providence. That's what led me to do what I do today. And every single day, I just get stronger and stronger and stronger every time I get a chance to witness family, and families always say, there's no way we can thank you. And I turn that around, I flip it, and I say, no, it's me who has to thank you for providing me the privilege of being with you at this most important time of your life. Now, the hardest patient I ever saw, who was the one who said to me, there is no such thing as heaven. When you bury me, I'm going in the ground, so why the hell do I want to die? And I had no answer for him.
And you're absolutely correct on that. I couldn't do this work if it weren't for my faith. I would be in absolute despair, just as that person was. And I would also reflect to you that the same thing is that I get so much more from doing this work with people than I can ever hope to return or to give. In fact, our major superior of the order that owns OSF that I work at is Sister Judith Ann. Sister Judith Ann reports that when we do this work, we are truly walking on sacred ground. And that's the mantra, that's the message that I take with me to work every day. How to address the spiritual distress and the existential distress of the atheist. That's what I would call the chaplain. I don't have a clue. I really don't. I'm sorry. I wish I did, but that's a tough one. Anybody else got ideas or thoughts or suggestions on that? Sure, go ahead. Go ahead.
I work with urologists in a regular medical practice, who happens to be my husband. And whenever the prostate cancer patient gets to that point that they're no longer responding to the treatment, they see the oncologist or go to radiation or whatever. And we never see them again. These people that I have been working with, when they were very active. And I often think now, when I start with those patients, I'd like to have them meet palliative care so that they aren't in horrible pain. That's not when they first meet them. The other thing that I have found I use when I talk to people about hospice is the fact that there is coverage for it. And when they're being bulky, I say, but they might get you your wheelchair. But I don't think I have the same argument for palliative care.
No, you don't have that argument for palliative care. The introduction, though, the answer is, this is somebody that you may need down the line, and let's get you acquainted with them before it's a crisis, because everything's always easier to do now than when it's a crisis situation. The earlier we get palliative care involved, the better. Reimbursement, challenging. Yeah. Yes, sir.
It's a cost question.
Sure.
If I were a patient in the hospice and it's been suggested to me that I need a PEG tube, it's my understanding that Medicare does not approve of that.
So the question is does Medicare pay for a PEG tube in hospice? The answer isn't black and white. And as I mentioned early on, when you talk to one hospice, you talk to one hospice. I work with a hospice agency, and our approach to that exact question would be this: what is your goal of care? What is this procedure, egg tube or whatever, related to whatever it is that you're dying from? If it is related to your terminal illness and you're in hospice, then Medicare, yes, you're correct. They said they do not allow for payment, additional payment for procedures related to your terminal illness. If, however, let's say you had, let's say you had lung cancer and you were looking at diabetic supplies. That's unrelated, so that certainly would be covered. But yes, the incentives in Medicare are for per diem payment for the terminal illness, but not for aggressive or curative therapy.
Would that apply also in a hospital care?
In hospice, hospital care, yes. In hospital palliative care, no. Palliative care, you can get any treatment. It can be given right alongside chemotherapy, peg tubes, surgery, anything and everything that is appropriate for you. One more, and I think Father.
I just have a comment regarding hospice. You come out of hospice immediately, and you go and get the care, and you come back. Because I worked in the senior program with people with their insurances, and that's exactly what we did all the time.
Yeah, you have to be a little careful about that, though, because if you go in and out too much, Medicare gets wind of that, and they don't like that either. So that's Medicare.
Thank you very much, Doctor. Very well. Well, we have come nearly to the end of our day. Thank you again for attending. I have one business question. Dr. Dolahite's wife is providing all the plans for the food that's going to follow the 5:15 Mass. Is there a show of hands of who is going to be attending that dinner? Are you counting Dr. Dolahite? Because I'm not. Okay, do we have a good number for that? All right, good. Thank you. The next speaker that I want to introduce, I have, as I have had for all of the other speakers, an official bio, but I do want to say something personally. Jack has been a personal friend of mine for 16 years. We braved January in Gloucester, Massachusetts during the long retreat. That's when we met. I used to be a Jesuit. Jack still is one. I no longer am. I had the good sense to join the Archdiocese of Chicago. But in any case, Jack's presentation is extremely timely, certainly relevant for all of the conversations that we've been discussing today. Alzheimer's disease, a challenge for the ages and for the aged. And as you can see, being a Jesuit, Father Sawicki is a Catholic priest. He's also a medical doctor. He's taught both at Georgetown Medical and in seminary system for the Society of Jesus. John R. Sawicki, Society of Jesus medical doctor, entered the New England province of the Society of Jesus in 1997 at the age of 48 after 22 years practicing geriatric internal medicine and later after a second residency and fellowship in geriatric psychiatry. Ordained into the priesthood in 2007, he was Associate Professor of Psychiatry at Georgetown University Medical School from 2002 to 2010. He left Georgetown to complete his tertianship in Australia. Currently, he is an adjunct at Boston College School of Theology and Ministry, teaching a course titled Pastoral Care of the Elderly, the Demented, and Their Caretakers, and Assistant Superior to the Community of Campion Center in Weston, Massachusetts. You can find his office at Campion Center by looking for the one with the bumper sticker on the door that proclaims Pennsylvanian by birth, Nittany Lion by the grace of God. And his last credential is that he makes terrific pierogi. Give you Father Dr. Jackson.
Thank you, Andrew. After 16 years, you pronounced Gloucester properly. You didn't quite get pierogi properly, but we'll work on that. My computer's booting up, I hope. It has been a really great adventure audiovisually here today. Initially, I thought this conference was going to be at the other campus down the street. I was delighted to come here this morning because the last time I was on this campus was November of, oh thank you God, was November of 1994, where I took my oral board exams in psychiatry. I'm a lot more relaxed today than I was then because, number one, it didn't cost me $2,000 to sign up for the exam. And at that time, it was the last time you could take the exam and get lifetime certification. Good news is I got lifetime certification. First hour was at the VA. Second hour was over here. And here, oh, the lecture is going to pop up. This is good. It'll pop up eventually. We're going to be talking today not quite as specifically about dying in the sense of palliative and hospice care. It's only recently even that Alzheimer's and the other dementing disorders come under the rubric of hospice. Back in 1977, when I was a second-year medical resident at Geisinger Medical Center in Pennsylvania, I had the great blessing and honor to spend 6 weeks working with Cicely Saunders at St. Christopher's Hospice in London. And at that time, she had had 1 or 2 patients in the hospice who had had multiple sclerosis. But because of the difficulty of setting a timeline up, she stopped taking neurologic disorders except for Lou Gehrig's disease, where one has a little bit better idea of what's going to happen. That's, this is good. All right. So we had the opportunity, it's only recently, and it's still a very big problem with Alzheimer's and the other dementing disorders because we don't know the trajectory. And it can be an exceedingly long one. The question of death with dignity, however, is a very important one in the arena of Alzheimer's disease because oftentimes one of Jack Dworkin's first patients was a woman with mid-stage Alzheimer's who was afraid of what was facing her. We oftentimes hear the families, I want my mom to die with dignity. Well, we all have inherent dignity. The challenge is when the family or the children refuse to recognize that dignity. And when they take mom or dad out to eat and have to take mom to the restroom or go looking for dad because he got lost again, did dad or mom lose their dignity or are the children more concerned about their own dignity? Getting lost is not a loss of dignity, it's an inability to do directions. And quite frankly, the reason I'm the youngest of a set of twins is I couldn't figure the way out. I said, Jim, you try. I'd still be there. So, first of all, some goals here. I'm a photographer, and I use talks to show my own photography. Most of which is what you're doing. This is Australia. The goals for this talk are to become aware of the incidents and definitions of aging and dementia, particularly aging, which is not a univocal phenomenon. Be aware of the differences between disease and illness, and cure and healing. Think of the ethics of medication for dementia. We don't oftentimes do that. We just figure there will be a pill. Consider what is suffering. And consider some moral questions. Alzheimer's has faces attached to it. Willem de Kooning, American abstract impressionist painter, died at the age of 93. The debates are still raging over the validity of his late paintings. And you don't need to be an art historian. Can you please close that door, please? You don't need to be an art historian to see the differences in his shots. Iris Murdoch. I read the review of her last book on the front page of the New York Times. It was devastating. She already had Alzheimer's disease. Then seated is Placido Domingo. This is Rudolph Bing, the dictatorial director of the Metropolitan Opera. He died at the age of 95 of Alzheimer's disease after an ugly, ugly court case where a 45-year-old younger than he woman got him to marry her. His estate was drained, she's in prison, he's dead. And finally we have Catherine Yaw, who died at the age of 93. Not of Alzheimer's, but of cerebrovascular dementia due to multiple small strokes. The artist, the author, the impresario, and the grandmother, who happens to be my maternal grandmother. They all lived active lives of loving and fighting and creating and doing and thinking and being, but in the end, they all died looking more alike than non-alike. So what about aging and dementia? This is a picture of a group of Sisters of St. Paul of Chartres in Saigon, actually in the Mekong Delta of Vietnam. Look at those wonderful faces. Some of them probably remember the war better than they were going to remember that we were at a performance of children dancing a little bit later. The challenges and crises of aging are increasing exponentially by the decade for both the patient, the family, and for society. The normal cognitive changes of aging are exceedingly complex. The cognitive changes of the dementing disorders, not just Alzheimer's, are even more complex. And bumper stickers that have sentiments such as a cure for Alzheimer's in our lifetime are absurd, they are cruel, and they are misleading. It ain't going to happen. Last week I was in Boston, which is where I live, outside Boston, for the American Neuropsychiatric Association meeting. And there were things coming up at that meeting, which I attend annually, new neurons that we didn't know existed, or neurons we don't exactly know what they do. An area of the brain called the colostrum is so ill-defined, we're still not sure what it does. So the incentive recently announced a great fanfare of $100 million in 10 years. We're going to map the brain. Bullshit. I'm kind of proud of that one. That was spontaneous. Here we have an old woman, her son and daughter-in-law, or maybe daughter and son-in-law, and a grandchild in Roosevelt Road in Taipei, Taiwan. What about aging? Once upon a time, that woman was young. And maybe she was pushing one of those two adults in a baby carriage. Now, we've already... Yeah, man. This happens a few more times, I'm going to have to see Father Borson for confession after. I do that so many times. Several speakers have already alluded to the change of aging with the past years. In 1900, life expectancy was 48 years, and now it's about 80. What accounts for the change from 1900 to 1960? One word. Antibiotics, absolutely, and public health. Later on, we're looking at things such as control of blood pressure, bypass surgery, chemotherapy, but the curve is starting to flatten out. A more interesting slide is the amount of life expectancy we still have. So at 65, and I'm close enough to throw this number in here, we can expect around 17 years. 75, 11, 94, at 100, 2. When I was a kid, 100 years old, you got your picture in the paper. Big deal. But But these statistics on aging are exceedingly old news. Psalm 90 put it perfectly. All our days pass away in your anger. Our life is over like a sigh. Our span is 70 years, or 80 for those who are strong. So, before we can really talk about aging, we have to define it, because it is not just one phenomenon. So first off, let's look at biological aging. This comes from Leon Cass on the other side of town, U Chicago, philosopher, physician. And he notes that aging is not a disease, but the body becomes less able to maintain itself. While you're sitting there, your body is expending vast amounts of energy doing maintenance, replacing cells, causing hair to grow, or in some unfortunate cases to fall out, and stuff like that, replacing the skin, relining the bowel. We become less able to do that as we age. Aging is not a disease, despite Botox to treat it. It's an inevitable decline of body and mind, even in the absence of other diseases. But it's a decline that, in the absence of a dementing disorder, can be accommodated for by wisdom. Something we don't often grant the elderly very much today. Cells only function for so long before they inevitably wear out. 60 is not the new 40. It's 60. I was ordained at the age of 58. And the two men ordained with me are younger than my college roommates' two oldest kids. So I told the boys, we were at lunch a few days before ordination, I said, hey guys, after the prostration, you look left, you look right, if I'm having trouble, for God's sake, help me. And then at the banquet afterwards, I nailed my twin brother, which I very rarely get to do. I said, Jim, in the public remarks, Jim, we're both late middle-aged men. But things being what they are, I'm going to be a young priest until we're 73. Sociocultural aging is something we don't think about too terribly often. And this definition from a French sociologist, Michel Philbert, is important because he notes, despite the biological processes which transcend culture, we can't define aging unless we pay attention to the symbolic context and the social setting in which the individual is aging. There are many images with which we grow up about aging that are cultural specific. It's been said that a picture is worth 1,000 words. Well, I've got 2,000 here in the next two photos. This is one of my closest friends, Ignatius Hong Guan Liu, SJ. He's in the room here somewhere. This is his mom. This is me with my mom at ordination. Our mothers never met, but they had a few things in common. They died 4 months apart in the year 2009, both of which were at the age of about 93, give or take a few months. And they both had their youngest sons ordained Jesuit priests. But beyond that, they grew up with two vastly different series of images about aging. Ignatius' mom in a Confucian culture that continues to respect aging and honor the aged. My mom in a milieu, okay, granted Polish Catholic, so we were kept in line. But in a milieu where being placed in a nursing home was one of the greatest things that a woman of her generation could fear. So socioculturally, they grew up with different expectations and more than likely, even if they could not express them, different understandings of aging. And then we have existential aging from Daniel Callahan. We all do grow old in other people's eyes before we do so in our own eyes. Now, there are a number of you who've had the experience. How many of you remember the first time you got asked the dreaded question, would you like the senior discount? Yeah, there's some things you really remember. The first time you drive a car, your first kiss, and the first time you're asked, would you like the senior discount? I was 55. It was Canaan, Connecticut. It was 5:30 in the morning. It was McDonald's. I was driving back to Boston from a friend's house. I said, don't wake up. I'll just buy some coffee.